No, please don't. All right, guys, we'll get started. Good morning. Last day. Thank you guys for joining us and not going to Sonic Games. All right, let you guys take a seat. All right, so thank you guys for joining us for a very exciting talk entitled From Spark to Solution, and we are going to be teaching you guys how to create digital solutions. All right, there's a bit of an echo there. I'll step back. None of us have conflicts of interest. And with the backdrop of the beautiful Grand Canyon, we have 4 speakers. I'm Andy. We have...
Hi, I'm Fran.
Jeff. Leland.
All of them, all of us, we are physician innovators. We have our own unique backgrounds, but we all have hands-on experience building tools from ideation to development and launch. All right, so briefly, just a quick overview. We want to go over a high big picture examination of how to build digital tools. The meat of this talk is really the case studies, right? So we're going to be spending a lot of time on that, and then we'll have a panel discussion and questions from all of you. All right, and so I remember, I don't think you guys are med students, but but I remember when I was a med student in SAEM, we did not have talks on AI, building digital tools, or large language models. When I was at the exhibit hall, I don't think we had startups pitching to us about their health tech solutions. So a lot of things have changed, and I would imagine that things will continue to change, and this will continue to be center stage for our field, because we're at an inflection point. And the thing that boggles my mind is, number one, this talk is totally empty, right? Because this is literally the current and the future state. The fact that we don't teach our doctors how to leverage technology or even learn how to build products or about generative AI or large language models, I think, is the problem. I feel like because it's going to be so crucial to their practice of medicine, it should be integrated into their curricula. And I say this because Fran and I, we actually hear pitches from startups in Silicon Valley. We've heard hundreds by now, and the best ideas and the best products have a doctor at the core of their team. Right? So I believe that, I would imagine all of you are physicians. You guys are the best place to understand the problem, but also find a solution. And with that, I'll hand it over to you.
Hi, everyone. Good morning. So, but we really want to hammer home that we really think that you guys, as the physician, are the missing piece. So, like Andy mentioned, what we're hoping to see, and we think we're seeing, is kind of an inflection point in the growth of digital tools. So people have actually been working on healthcare technology for a while, right? When I remember doing my master's thesis, people have been working on various solutions since the 80s, surprisingly. However, there's still such a lack of technology and digital tools in medicine compared to like finance or like astrophysics and things like that. And so medicine and clinical environments are a hard space to develop for. It's a deeply vertical. We're all we move very fast-paced, and for a tool to be incorporated, it needs to have deliver a lot of impact and fit within our existing workflow, or somehow dramatically improve it, or else we won't adopt it. And this always requires a collaboration between the physician and the people who are going to build it. So you will always have a very central piece in this. And having built solutions with industry and academia, I really think that the physician is, fortunately for you guys, a linchpin. So where the crucial role comes in is to identify a need. Now, this is a one-liner, however, I think this is really the most key part of this, and where Andy and I see the most downfalls, if you will. So, in industry lingo, the most common term for this is called finding a pain point. And so, this, so to give an example, this is really an iterative process, but to give an example, for example, if I want to say, hey, I want to catch more people who have ACS and reduce M&M in that, there's so many ways you can attack this problem. A very myopic approach could be saying, I want to make ECGs faster. But as you can imagine, identifying ACS, there's so many ways to attack this problem, and without taking a more global approach and thinking about what's really going on in the clinical environment, how much impact would you really have? For example, you could address the ECG issue. Maybe it's more text. Maybe it's getting cardiology colleagues on earlier. Adjunct technologies like adding echocardiogram. All of these can help you find the solution that has the most impact. And so finding the pain point is an iterative process of asking yourself over and over again, what is really the need? What is really the need, and how can I best address that with my interest in the team that I have? Then comes the fun part. Once you think about a need, is brainstorming the solutions. So I think many of us have been part of good brainstorming sessions and less good brainstorming sessions. Probably the better ones that you've been to have a really great moderator who's really open and helps expand the discussion, because you need to expand the discussion as far as you can first before kind of narrowing down. Lots of visuals, whiteboards, and especially having people from a diverse range of backgrounds. So your clinicians, your engineers, your ops, your nurses, all as multidisciplinary as you can make it. And this is where you identify the aspect of the problem that you want to solve. Next is prototyping. So as fast as you can, start building a version of your product. So whether that's hardware, so like a device, something that's physical, or software, the faster you can start shaping the problem and putting your pen to paper, if you will, and into reality, the faster you can see the shape of your solution and how that might take on. Which moves to the kind of climax of all of this is, the initial one is to define your MVP. So many of you guys are probably familiar with this term, but a minimally viable product is the first step you could take. It is the most stripped down part of your product that you could develop and put in front of your users as soon as possible, that still contains the core features to deliver your value so that you can iterate. So it's really hard because you have this ambitious grand idea and you want people to understand it and see it for what it is right away, but it's important to really strip it down to the most key essence so you start iterating. And I'll turn that to you.
All right, thank you, Fran. So if you guys are like me and have ADHD and prone to zoning out a little bit, I would say if you remember anything, it's this slide right here. Kind of reminds me of the build, measure, loop in the Learn Startup book, but basically, in essence, you have a need, a question, and you want to research it. You build a prototype, an MVP, you test it, you see how it does, and you make it better. And you go round and round and round. Essentially, this slide encapsulates the core, I guess, essence of building a product. And we'll talk more about that. This is really, there's a lot to unpack here, but just a high-level view of digital strategy, I want to say is basically who are your users? Because you want to optimize for them. Is it the doctors? Is it the patients? Next, how do you fund your work, right? What is your way of funding it? Because basically you have to pay your staff and you have to pay yourself for the great work that you guys do. Is it funded by your department? Is it funded at the enterprise level? And what is their incentive to keep funding you year after year, right? Also, is it donor funded? Are you paying directly to your customers or to other businesses? These are questions you guys have to solve when you even think about making the step to build a product. And lastly, who are your stakeholders, right? Because these are the potential decision makers or influencers who are going to decide if you can even build this thing. All right, and then lastly, how many of you guys, I feel like there's a lot of attendees here, but how many of you guys have actually read your intellectual property agreement? Raise your hand. Yes, I know you have. For those of you who have not, shame on, no, I'm just kidding. But I really encourage you guys to read. I read all 4 IP agreements in the 4 different hospitals I worked at. I cried a little bit, but you guys put in a lot of hard work and labor, right, to the hospital, very valuable, but your ideas are also just as valuable. And you guys I feel like you should feel empowered to have ownership over your ideas. How do you protect them? And if not, if strategically it makes sense to give up ownership, to leverage hospital resources, and to de-risk your project, then what are the benefits of doing so? It's really important to think about that stuff. All right, so I want to share a story with you all, okay? Just a little bit of background for me. I've spent about 10 years building product, and I have built over more than half a dozen digital solutions, but this one is very special for me because this is me, intern year. And that is my good friend Monica, and we shared many trials and tribulations in the ICU. It was very painful. And she's a brilliant doctor, and I remember one day she got sick. So my junior, I don't know if you guys know Chris Carney, he's a character, and I had to manage the entire ICU floor. And it was very hard. And at the end of our 24-hour shift, where I was extremely delirious, our patient coded, and it was essentially my first code. It was so hard that I actually took a picture of it to remember it forever. And would you guys like to see it? All right, yeah, it was an absolute dumpster fire in the sense that at the end of 24 hours, I just could not remember the steps of the ACLS protocol. I don't know if you guys actually carry the paper card. Do you guys, anybody carry that? Absolutely not. And I didn't either. And so I was just trying to remember the steps, and I felt very guilty not providing the highest level of care that this patient deserved, and unfortunately couldn't get ROSC. But in my mind, in my desperation, I was thinking to myself, I wish I had a digital adjunct that could walk me through this, that doctors could use at the point of care, right? App for doctors, at the point of care, where even if my brain was mush at the end of 24 hours, I could serve this patient right. And my colleagues, Jared Conley, who's my fellowship director, as well as 2 internal medicine residents, brilliant people, Melvin Joyce and Blake Nickham, we got together to build an inpatient app, for inpatient emergencies. And as we were developing this, then COVID hit. And I remember that there were a lot of redeployed doctors that were staffing floors that were filled with coding COVID patients. And that was sort of our impetus to move faster and create a ACLS app, essentially. All right, get ready, guys. So as part of my fellowship project, I wanted to create an ACLS app, so I spent a lot of time sort of designing and drawing what that could look like, all right? And this is it. Yes. Maybe some of you guys are impressed, but I think this is very, very basic, and I actually designed this on Keynote, right? And I know what some of you guys are thinking. Some of you guys might be thinking, wow, like this is so basic that a child could draw something better than I could. And you're right, they could. But that's the point. I think the beauty of this slide is that you don't need to be, I'm not a Da Vinci, I'm not artistically talented, but you don't need to be talented. All you need to do is convey the basic ideas and designs to a designer, people who have that expertise, and if you can share your vision with them and recruit that team, then they can actually bring your idea to life. And so that's what I did. So teamwork makes the dream work, and I got to co-lead a multidisciplinary team within the MGH Healthcare Transformation Lab that included software engineers and UI UX designers, and together we brought that idea to life. And so they're much more talented. So you guys remember the Keynote mock-ups that I did? A much better version of that. But you can see here that we were able to build high-fidelity prototypes, right? We didn't build the code, we just had the designs on Figma, and we go multiple iterations of this, getting feedback from doctors, because it's essentially the same thing. And then once we were all in agreement that this is a product we want to move forward with, then we built the code, and we were able to do that very, very quickly. And so you guys remember the sort of build, measure, loop, learn loop cycle that I was talking about. This is sort of like holy grail, sort of the North Star for me. But now you see that I've added stakeholders, and I'll show you why this is so incredibly important, is that the next slide, you're seeing a stakeholder map. Have you guys ever seen something like this before? Maybe some of you MBA colleagues out there. I see some nods. So basically, the bottom half, right, that is my stakeholders within the hospital that I'm working with. That's MGH. And the top half are the stakeholders outside in the community, right? The blue circles are the decision makers. They are the stakeholders I need to get their buy-in to even build this thing. And the yellow circles are the influencers who can really help me or really slow me down. And so, of course, are some of our most important stakeholders, the doctors, you guys, our users. We optimize the experience for you, and also our patients who stand to directly benefit from the work. But they don't decide whether we move forward or not. We also have the hospital incident command system, super helpful for making us a high-level priority at the health system level, right? But their support allowed us to move very, very quickly forward, and what would take us months, because of their support, we were able to do in a matter of days to a week. Also, in order to move forward, I had to get the support of the general counsel, and I remember reading lots and lots of legal documents, as well as a risk review by by IP and the risk review office, because we decided strategically to leverage the MGH brand and their longstanding relationship with the AHA to build an app, and so we needed all their stakeholder support. Additionally, the AHA, we had to convince the executive leadership to allow to get access, license to their intellectual property, and they have been one of our biggest supporters, so big shout out to them. And with that, we launched in 2020. Fast forward 4 years, and now we have tens of thousands of users in over 150 countries. I'm sure some of you guys are using the app as well. And even now, we are still getting user feedback. We are continuing to iterate, always examining and being very attuned to the needs of our stakeholders. And then, also just a big believer in the build, measure, loop cycle. Still using it. Thank you, guys.
Hi guys, my name's Leland. I'm faculty at Brown. Oh, I don't know, I'm so much louder. I'm going to talk through my case study following up on Andy's, and I think what I have to offer is the perspective of someone who had no background in tech, but with basically some of the concepts we're talking about here conveyed to me and a little mentorship from yours truly, Andy over here, I was able to create my own successful innovation. Boiling it down to the elements of what makes good innovation that we've already touched on, throughout my case study, I'm going to bring it back to these key elements, just so if you don't walk away with the story, at least you know why this is going to do innovation and what made it so that hopefully you're able to apply these concepts to your own thought process as you go through this process. Starting in order with the problem, as we kind of talked about, you have to have a well-defined problem, and it has to be something you know really well, so like the back of your hand, I would say. There's an advantage being an expert in something, us being emergency medicine doctors, or me being an ultrasound. We know the problems that exist in our field, and an easy way to find a good problem to solve is just by knowing something well. You know what you need to target. And this is relevant because if I were to set out to say, solve a problem in something I don't know, say in the restaurant industry, I probably would need to spend a lot of time first making sure I have a good, well-defined problem that needs solving, and probably some expertise in that field. In my case, throughout ultrasound fellowship, I noticed, as many of you have, I'm sure, it's very resource intensive. It requires a very low learner to teacher ratio, and this is a reason that it doesn't really disseminate it, probably to the extent that it should. This was a survey done in medical schools a few years ago, and while nearly all of them agree on the importance of ultrasound in undergraduate medical education, very few have a real curriculum, this still being the case a few years later. And they all identified similar barriers to implementing their desired curriculum that basically boil down to not enough resources. So I had this problem that I knew was important to solve, and I knew like the back of my hand, being in ultrasound. And so that's the first element of good innovation, is having a good problem, and starting in that order, then to find a solution that's tailor fit, and not to start with a solution and finding a problem, which we often see, for example, with AI, and because you can make a tailor-made solution. So the next element of good innovation is a tailor-made solution. And so what I set out to do is to try to recreate the process of doing an ultrasound at the bedside and what learning comes from that. This is some of my initial sketches in my solution. I tried to imagine that the user should be able to move around a probe and obtain images, interpret those images, and integrate them into their clinical decision making. So kind of focusing on that concept I just described. Obviously we have the real thing, which is the gold standard, let's say, and in trying to recreate that, I went through a few different iterations. At first I thought I would do VR, where you would have a probe and move it around on a mannequin, but touching on the next element of innovation, feasibility, this was not something I knew how to do, and I couldn't have the resource. I didn't have the resources to pay someone to do this for me. I then settled on the idea that maybe we'll have a JPEG where if you click different boxes, you would get the corresponding image, just like if the user was ultrasounding themselves. But after building only one case like this, I realized it's very resource intensive. I had to get hundreds of clips from the same patient so that it would be synonymous, and it ultimately wasn't very feasible. What I eventually settled on and I realized is that when you're performing POCUS, you only need a few key views, and you can convey this concept by only having a few clips for each case. And this is finally what allowed me to start building multiple cases. And the reason this is able to show feasibility is that you're able to look at it. If I were to show you essentially this MVP, as we kind of touched on, you're immediately able to know, hey, this is possible because the guy already did it. If I were to give additional resources for this, it would obviously be able to do more of the goodness that you're seeing on the screen right now, which is a lot more powerful than me kind of trying to describe something that I haven't actually built yet. So that's the importance of the MVP, is showing that it's obviously feasible, and that if you were to support it, I could do exactly this. And it does take some resources, mostly sweat equity when you have no money, but in a lot of cases your own money. And I would say if you're not willing to put at least a lot of your own time and money into it, it's probably also not an idea that you shouldn't expect other people to support, right? And so it's important to get to an MVP, to show other people that it's possible, and that you yourself believe that it's a good enough of an idea to follow and pursue. This next concept I want to touch on is end user focus. And this goes back to the build, measure, learn cycle that Andy had kind of described. So we build our MVP, and then we, as soon as possible, when you have the simplest possible thing, which I'm kind of, what I had on the previous screen, I then brought to the learners at my institution. You want them to get using it right away. And this is important because if you stay too long in the build phase, which traditionally was done, you're going to end up building a lot of features that you think people will use, but they might not. And what might actually be useful from the product might be unexpected. It's impossible to fully predict how the end user actually interacts with your product and if it's actually solving the problem that you want it to solve without actually getting them to use it. And this allows you, together with the end user, to make the innovation so that you have empathy and end user focus with the end user, ultimately with your product. And so the way I measured this is I took this, I gave it to all the interns and medical students, or made them use it, and the half that used it did better on their existing ultrasound exam, and then we got a lot of survey feedback. And when we incorporated this, we lead into the elements that they really liked. We took out the elements they didn't like, and you can imagine after a few cycles of this, now I had a tool that has data supporting that it works in its intended purpose. I have data showing that these are the changes we need to make if I ever wanted to approach someone else for support, let's say funding, which is a lot more powerful than saying these things. You have actual data supporting it, which goes a long way in product development. Ultimately, this is one of the much later versions. We eventually created a mobile app for it, and there was a lot of other features and design changes you could see in the clip here. And then kind of ending, and on the most obvious and intuitive aspect of good innovation is the impact. And in the best case, you should have a large-scale change enacted on globally. And what happened once we launched is we got thousands of users all over the world with very positive feedback, and to this day, some of the residents at Brown took this and built their own modules within Ultrasound Box and presented this yesterday. So I hope at least you're able to walk away with, hey, these are the key elements of good innovation, if not the story yourself.
Hello, I'm Dev, also Stanford faculty. I'm going to be presenting something that's more or less in the works rather than established products that Leland and Andy have already built out. So the slides are going to be not as intricate, but hopefully closer to kind of where maybe the audience is in terms of conceptualizing a product in the sphere that incorporates AI into the decision making. I work at the enterprise level on various AI projects, and I stop and accelerate projects that don't make sense and do make sense respectively. And so I've had quite a bit of insight over the last 2 years on what works, what doesn't, what strategies we should employ. And so again, to kind of focus on what the previous speakers have hammered on, is figuring out the problem is absolutely critical here because it defines your personnel requirements, it defines your data sources, defines your methods, and it defines downstream ROI and how you're going to pitch it to your leadership, to other faculty, to your key stakeholders. Most of the time, the problem that you envision in your head is actually not the exact problem that's going on. So, for example, we have an issue at our institution, and many other institutions have, is we don't build critical care appropriately. But what is the actual problem? The actual problem is we're not assigning the right CPT codes to our charts. And so we have to keep pushing and figure out the narrow problem that's kind of plaguing our institution. And this sentiment is actually echoed with our previous speakers. Andy's part of our biodesign faculty fellows, and they spend 6 to 9 months trying to figure out the actual problem before they build teams and products around it. So once you've figured out your actual problem, for example, CPT codes are not being assigned to appropriate charts, it's important to establish baselines and determine a gap. So whatever the national baseline is, it's somewhere around 15 to 20% for academic medical centers that should be billing for critical care. At Stanford, our low acuity populations a little bit lower than other places since we're not really a county hospital or kind of we don't treat that population as frequently. Our critical care percentage is probably higher. So that helps us determine what the gap is. And once you have a gap, you can turn that around and say, if I fix this problem, the optimal solution would get us this much ROI. And so that's also key in helping make an argument to your leadership. Finally, when you have your problem, there are also sub-problems you should go after. So why are CPT codes not being assigned for various reasons? There could be all sorts of reasons, and the people that have the answers here are the people at the ground level. You know, most of the time leadership probably can't define your sub-problems for you. So you have to go right down into the shifts and ask people, why do you think this is a problem? What do you think is going on here? It very much echoes a brainstorming session that was spoken about earlier. Once you figured out the sub-problems, you can categorize them and build technologies around them. In our case, we want to use a large language model to identify charts that would meet critical care billing criteria. And so this goes into trying to leverage institutional resources and figuring out the motivations of different teams. So you have clinical informatics teams that want to like build charts at the appropriate level, but you need the help of computer science or biomedical data science. Well, guess what? If you go to many of these teams, they're very reluctant to tell you that the problems that we face in medicine are so simple that it doesn't advance their career to work on these. And that is not a sentiment that they'll tell you straight up in your face. You kind of have to know them because they're essentially telling you that we don't really want to work on this project because it doesn't advance how I'm going to get to my next stage in my career. And that is such a critical gap at so many academic medical centers that want to interface with domain experts in AI and incorporate AI into clinical workflows. So the key solution here that I've found worked really well is we have to spend time in their domain and they have to spend time in our domain. And I'm going to touch on that a little bit later. Finally, once you have your team, you have to assume that the version 1 product you build, that minimal viable product, is not going to be your final product. And once you've accepted that, and you accept that it's going to be version 5 or version 6 before you feel really, really good about this product and you're ready to share it with the rest of the world, you have to continue to review and fine-tune the methodology. And this is the whole testing and iteration steps that was discussed by the previous speakers. Finally, you have to establish some sort of an intervention point because every solution that you design, it's always around like a board table, around Zoom meetings or something like that, but every solution fits in some part as part of like a temporal clinical workflow. So step A happens, then step B happens, and then your AI kind of AI model works, and then you have downstream steps after that. So you have to figure out exactly where the intervention sits, and then figure out the stakeholders that surround that intervention. Sometimes it's nursing, and sometimes it can be very difficult to get nursing teams on board because they're all busy. You have to convince another whole slew of leadership. And so thinking about the intervention point early is also critical here. Finally, we always talk about like key slides. This is kind of a key slide. So there is expertise that you already have, and this is very often downplayed because we see it as a routine part of our daily life. But if you go to, if you describe your job to people who are not in medicine, to engineers or finance people, and we take people that take people back from the clutches of death or change their trajectories, that change their career trajectories. That is incredible. And so that's expertise you already have. But there's also resources you should ask for. So at Stanford, we have an internal kind of a emergency medicine data lake that's been built by our department. And so if you need something like that, or you need particular resources, you should feel empowered to go to your leadership and say, this is what I want. I want money for a graduate student so they can do what I want them to do, or like 50% of the time. I want money for compute infrastructure or hardware so I can like pilot some of these projects. And finally, there are skills you need to acquire. So critical for me is to spend time in the computer science domain. Anybody here heard of Google Colab? Yeah, nice. So it's a Python environment in the cloud that's free for everybody who has a Google account, and even if you don't have a Google account. And so I spend time in Google Colab piloting some of my ideas, and then I tell my CS students they got to join me in the trauma bay at 6 a.m. And they're always like, 6 a.m.? Yeah, it's 6 a.m. That's when the shift starts. We're going to take sign out, and then we're going to go see some patients. And so I drag them to the ED. They have a great time. They're always hesitant to show up at 6 a.m. But I also spend time in their domain trying to figure out what they care about, what they like, what's on the cutting edge. So that interaction is super helpful in terms of helping designing a product. pass it over to Fran now.
Okay, so I'll be talking about the last case, so you guys are almost done, don't worry. Okay, so to start, so I'm an engineer first. I study electrical engineering and computer science, and actually have been an engineer longer than I have been in attending. I was a giant nerd, and for example, this is one of my favorite projects. I developed that motor controller to control this version of the Da Vinci robot, which you can see is tying a knot here. Then I worked on other software projects. I assume some of you guys may have this in your pockets right now. This is Outlook on iOS. But what I want to talk to you guys today about is actually a negative case where I learned a lot from. So how many people here have heard of Microsoft Amelga? Okay, good, one. Okay, I was that's 100% more than I expected. Paradigm is another name for it once it got acquired. But anyway, long story short, Microsoft Amelga was this Microsoft product that aimed to be like an EHR on steroids, if you will. So it was a product that was started by 4 actually emergency medicine doctors in the ER at Washington Hospital Center. They had a lot of local user uptake and sold it to Microsoft, which then formed a division. In this division, Azixia, yes, it was Azixia. Yeah. So in this division, we actually had 40 doctors on staff, many of which were emergency medicine doctors, and hundreds of engineers that came to join this team from all over the organization. So they left their cush jobs at Word and Outlook, et cetera, to come join this startup within Microsoft. So what is Amelga? So Amelga, first of all, I realized that a lot of the screenshots that I actually kept for myself are proprietary, so I had to Google some generic images. But so Amelga effectively aimed to be like a data science tool for clinicians. So for example, you could build like a view or a list for yourself that goes, I want to find all my patients who are smokers who live in Williamsburg, and I want to see how many of them live there versus Upper West Side of Manhattan. Or maybe more relevant for emergency medicine doctors, I want to see how many of my patients who I said to follow up ortho actually did, but didn't have insurance, who live in a specific neighborhood. So basically, it was a platform that took all the data in, the clinical data, demographics, finances, imaging, like all the data that the hospital had about the patient, coalesce them in one place so that you could effectively kind of analyze it. As you can imagine, this is also a great research tool. And so this is a pretty complicated product. It required a lot of engineering resources. As you can imagine, hospital databases are hard to work with. Many of you guys know that, et cetera. But the 2 takeaways are here is that, so the ultimate takeaway is that, unfortunately, this is a product where, sounds like none of you guys have heard it. It eventually fizzled out. And so why did that happen? So a couple things. First of all, obviously, so this product was built over like 5 years. We had many large contracts. Hopkins, New York Presbyterian, who I worked with, HCA, which as you guys know is one of the largest healthcare organizations, et cetera. But it turns out not many physicians, not a large majority of physicians don't necessarily need to do analytics on their patients. While this is useful for many of us, maybe all of us who are nerds, a lot of the admin, informatics people, who were probably the people who the negotiations and design was done with, turns out the average clinician doesn't necessarily use this that much, or at least not enough to overcome the installation, implementation, and cost of this technology monstrosity. And so, going back to what we talked about earlier, identifying your minimally viable product, iterating. Did we do that enough? Did we do that with the right people? And in addition to making sure that your product is useful, even if you have a ton of users, which this did have a reasonable number of users, is it enough to make it viable from a business and commercial perspective? Was it enough to overcome the cost and the time of implementation, the cost of the product, of upkeep, and things like that? And although, as you can imagine, Microsoft, for a private company has infinite resources, the balance of the number of users it has versus the cost just didn't quite work out, and which is why many of you guys haven't heard of this. So I wanted to tell you this story to kind of talk to you about, to illustrate kind of the importance of iterating early and in front of the right people. And from a personal perspective, I will say, because this is something that I want to share that I don't hear about often kind of in this space, is, so one of the things that was most disappointing for me is when we first started this, there's a lot of engineers that joined us from all across Microsoft, many of us who never had worked in healthcare before. And all of them joined these, it's like bread-eye interns. They're like, we wanted to help people, we wanted to change the world. And when this slowly died, I would say a lot of people were like, oh, I don't want to work in healthcare. I don't want to work with doctors. It's too difficult. And a lot of them are like, I'm going back to working on, I don't know, whatever Microsoft Music, Azure, or whatever Microsoft Music player, which I can't even remember because I'm a bad Microsoft team. And that was like really sad to see. As a doctor, obviously, I think healthcare is the most important thing. But unfortunately, the most of the best engineers work for like the big elite tech companies or sexy startups. And so I want to share this with you because there are steps that we can take to make it easier to work with engineers and to attract the best talent, which is something we can talk about during the panel. And so the three things that I always emphasize, which I took away from 4 years of working on this product. One, we talked about know your pain point. Is knowing which patients don't follow up with ortho a pain point? If so, for how many people? And how much should we invest and build for that? Iterate, especially in front of the right people. And the last thing is like how it's built matters. So I think a lot of clinicians, we work with engineers, we go and tell them, but we want to address clinically and then we kind of walk away. But how it's built matters. Like talk to your engineers for at least a little bit on the overall high-level architecture. Is it a technical monstrosity? Is it going to take way more to build than people might use it? Do you have to build a custom installation for every site? Because that takes a lot of time. So these are the three things that I really want to make sure we emphasize, and I think we talked about in each of our studies. So as an example, this is my current research. One of my other interests is ultrasound, so I wanted to develop an app that helps you identify regional wall motion abnormality to better earlier identify ACS. So I want to effectively have a platform agnostic way of doing this where you can just point your phone at an echo that you take bedside and it helps you recognize regional wall motion abnormality to kind of sell this to our cardiology colleagues. This is a wireframe, so this is an early prototype that I brainstormed. But what's the core of this MVP? What's the part that I want to develop and test first? It's the imaging algorithm. And so let me see if this plays. But basically, I want to make sure that the algorithm works, that it effectively identifies regional wall motion abnormality, and that it can be platform agnostic, because the rest of the app is less useful. So this is an example of focusing on MVP, developing that first, putting it in front of users, making sure our cardiology colleagues agree with this, so that it can actually be dispo changing, and the rest of it comes later. This is another quick screenshot. So you can see basically what I'm trying to do is to measure changes in wall thickness. And so this is some of my early data, which shows its effectiveness. But regardless, still need to test at the MVP before I build the rest of it. And so with that, I'll turn it to our moderator, Dr. Chu.
All right, so moderator panelist, essentially. I feel like I was expecting a couple more, learners and medical student level attendees for our panel discussion questions, but it seems like we have a very esteemed, experienced colleagues here. If you guys actually have any questions for our panelists to field, please, you can raise your hand. All right, we're expecting some softballs, but please throw a fastball for us.
I'm really interested to hear your thoughts on when you do great work like you guys have done, how you stop these products from coming out of date. If I look at my phone now, I've got a whole range of medical apps. Probably 60–70% of them are no longer updated. Look, they put the work in, and then they move on to the next product. So how are you going to avoid that with the great work that you've developed?
So if I understand your question correctly, how do you maintain updating and sort of maintain and upgrade the software that you've already built so that it doesn't become essentially in the graveyard? Is that what you're saying?
Yeah, particularly with, for example, the code algorithm.
Right.
Because I work in pediatric emergency.
Oh.
And I've got so many peds, weight calculator apps, that type of thing, algorithms. And 2 years later, they're out of date because people have put lots of work in.
Right.
But then they don't have the time to continue to commit to update them.
Yes, The hardball questions came early. I'm happy to answer that question, but if you guys also have some perspective on that too, because you guys have built like products, maybe not an app, but a web tool or other tools, how do you fund and maintain your work currently? And I'll answer that as well.
I mean, obviously, I think you describing how HACLS is maintained would be a great perspective. I think it's the key question in innovation in academic emergency medicine is there's a lot of incentive to create something and then implement it, and then there's no academic fruit for like continuing that. And so the hospital spends all this time and money to implement this thing, and then it's not updated and it's useless a few years later, and then everyone's disillusioned from ever doing that kind of thing again. It's a question that I think people need to ask themselves when they set out to do the innovation, and it should be asked of them when they're trying to implement these things. And so I think there just needs to be increased awareness at all sides that not only does the product have to be amazing, but there has to be a plan for how it's supported. And I think HACLS is probably one of the examples of how that can be done. And there are other ways, but if you want to describe, I guess, Andy.
Actually, my hardball question to you, Leland, is actually how do you maintain and fund your current work with the ultrasound box? And I can answer mine as well.
It's a good question, and okay, so if you want my perspective, I'm faculty in ultrasound, and that's my passion project, and obviously with a lot of resident labor, I'm still building modules that are benefiting people, but in terms of funding or what's going to get me further in my career, there are certain zeitgeists in emergency medicine. I've kind of leaned into regional anesthesia and have a lot of grant funding from that, and it's taken most of my time and taken away from this, and while this project could do a lot more if given the time, it's I guess not in my interest and to the sacrifice of the project. It's an example of, I guess, it not being maintained or grown as much as it could be because of those misalignments of what academia prefers to see of its physicians in the traditional sense. You know, I'm supposed to get a K and then an R, which is incompatible with ultrasound box.
And I love that honesty, and I think that's the value of talks like this is just sharing that pragmatic advice. So in my case, I feel like in medicine, the word business is a very dirty word. But I mean, healthcare essentially is a business, and any product or tool you develop, you have to think about the business model that drives it. So there is a graveyard of apps, a graveyard of, blog posts like foam, websites, because there's no funding mechanism. So for the MGH ACLS app, now rebranded as the AHA app, we were very intentional about thinking about the 3-5-year plan. So for example, thankfully, the first phase was donor funded, right? The innovation lab, a lot of these staff are funded by generous donors, but that lasts only for so long. And so we were very intentional about working with the AHA and then actually having our app on the App Store and then having a subscription model that has allowed us not only to break even, but also to be cash flow positive. Now, our goal is not to make money or to be very rich. I will not get rich off this app, but the point is actually to have a self-sustaining model. So thankfully, the requirements to maintain the app is quite low, right? Because the ACLS algorithms update every 3 to 5 years. And so you just have to update those algorithms. The features we can build them relatively quickly, so we don't need a full-time staff to maintain the work, right? Maybe 0.1 FTE with a relatively experienced software engineer, and then the revenue that comes in will cover those costs pretty easily, right? So those are the type of strategies you have to think about, especially as Leland was saying, your interests will change over time. And so as you start preparing to write the KR1 grants, you ideally want to think about a way for this app to be self-sustaining that requires a sort of minimal oversight, essentially. That's just my humble opinion. Yes.
So I have a question about teams.
Hard question too. Yes.
I want to give it some context.
Yes.
So that because I do want to hear what each one of you think, and I just wanted to say what I thought about your teams. So, I was surprised when on the app you showed your team, and it seemed like a lot of people to me. But then, it really is a viable product that's paid for itself. And I thought, maybe that's what I need, because, I always want to be more successful, right? And so I thought, maybe I do need a team that's big like that. But then, on the other hand, I think of the team like Amalga, and you mentioned it as Amalga, but the people in the room who probably know more about it as a Zixi, because that's when it was a very successful product. And Amalga was a failure because Microsoft. And I don't know what you were in that team, but I was familiar with it, and there's a lot of reasons why it failed, and mostly they were not because of the doctors they hired. And so, and I thought about that. I think team versus volunteers in the team, and what the currency is, essentially? Thanks.
Hardball questions come early. That is literally the hardest question. Why don't you guys, I'm curious to hear your perspectives and I can share mine.
I mean, since you mentioned about that,
Yes.
I'm loud, right? Am I loud?
Oh, you can.
Pretty loud.
We also.
Yeah, I think I'm pretty loud. Since we have a small team, I mean, since you talked about Amaga, I mean, so first of all, I agree with you. You know, Azixi had a lot of users compared to this team it had, as opposed to, you know, the ratio was much better than what Microsoft had. I don't think that the fault was all with the doctors. I mean, to be honest with you, I don't think, I mean, pinning on any one person, I mean, management, et cetera, obviously always is where the buck stops. I think for me, I guess the part that I'll talk, we can talk about this for hours, right? But the part that I'll speak to the most is in teams like this, when you're building a clinical product, I think the biggest chasm that I've always seen is the difference between how engineers and doctors think and work. I don't think it was the doctor's fault by any means, of course, but I think the way this interaction often goes is an engineer comes and is like, I have the solution. Do you find it useful? Or what can I build for you? And doctors are like, oh, well, this thing is annoying. Can you fix it? And then they'll tell the engineers, and engineers are like, will focus on that and say, okay, I'll build for this product. But the thing is that when you focus on one piece, then you realize, okay, I may have made the hammer for this nail, but then the doctor's like, okay, well, I have this other problem. But then had you talked about the clinical space and really kind of the overall approach, maybe the engineer could have built something that was a little bit more scalable or growable. And instead of them building a one-off thing for the one product, for the one problem, itch that you wanted to scratch, etc. So that's a very simple example, but I think to me, and one of the reasons that motivated me to train as a physician after being trained as an engineer was because of the way that we speak and communicate so differently. And so I guess the thing I would encourage all of you when you do work with engineers is to really think about not just the one problem that you want to talk about, what else it could grow into, because that really helps the engineer think about that. Anyways, the team's question is such a big one, but and I'm happy to speak to all points of it, but that's the one aspect of the team that I took away most from my experience.
Something that's important here is to provide as much context as possible to all the members of your team. Personally, I think you should probably have a very small team when you're building out the initial product. However, focusing on that sub-problems of the actual problem that you've determined is providing context to the rest of your team, especially non-clinical team members, in that you say, okay, well, I've broken this actual problem down into four different sub-problems, and I've kind of ordered it by low-hanging fruit. So we'll do this first, and then we'll do this, and then we'll do this, and if we solve all of these problems, we'll actually fix our primary problem. And so if we focus on one narrow sub-problem, that's the issue we get into that Fran was talking about, where when we try to pivot into sub-problem number 2, it's like, oh, if I had known that, I would have structured my database a little bit differently. And so scoping out all the sub-problems and building a layered approach kind of keeps your entire team on board. And as far as build additional members and when to expand, and you're essentially asking how much credit you give out, whether it's monetary credit or academic credit or something like that. That I think has to be decided top down by the leads of the minimum viable product. And so you and your buddy build an initial product, and maybe a software engineer, maybe you don't need one initially. And then as you expand this expand into other sub-problems, you decide you need additional help. And sometimes it's just emergency medicine help and doesn't have anything to do with informatics or AI. And so you would want to dish out kind of credit appropriately there. But it should come from top down, and the decision to expand teams is not an easy one to answer. And you often clash into bandwidth problems with other people, because people computer science students and PIs and other faculty here, they're not just sitting around waiting for you to call them. They're usually busy with other things. So it's a complicated question as to when and how to expand a team, and sometimes you don't have personal control over it either.
Yeah, I think one thing that helps is also, I was fortunate and unfortunate to just grow up in a very entrepreneurial family, but learning quite a bit in terms of teams and when to grow. But Leland, I'll have you speak on that first. Oh, no, please.
No, I mean, I was just going to comment, because my project was mainly entirely within academia, I view it as a feasibility problem, right? I hone in on a solution, and then I think, okay, what are the skills I don't have that I need in order to make this project viable? In my case, I had no experience in launching a site, a format, successfully within the ultrasound community, so I approached the guy who did it the most successfully, something called Focus Atlas, Matt Racinti, and he joined my team to give very little of his time for a lot of ROI if the project's successful, and that was enough to allow him to give me all his wisdom on this. I had Andy help me out too in the kind of the business aspects of making it successful. And if I wasn't able to do that, maybe I wouldn't have moved forward because maybe it would have been a waste of my own time, because those are skills I don't have and would not have been able to complete the project with. So in some ways, at least for me initially, I viewed it as a feasibility problem, and it was very clear to me what I needed. And then I tried to secure people who had those skills before putting more time and resources into the project.
And then, just my humble opinion, I do feel like, again, business may be a dirty word in academia, but the skill sets you get translate so well into every industry, including medicine. And so what I mean by that is the most productive I've ever built in building the most complex platform I've ever built was with 3 people. A medical student helps me, we also had a software architect and a designer. And the 3 of us were more productive than, I would say, large teams, because we were very focused, our values were aligned, and we were just 100% in. Now the challenge is, I think growing and building teams depends on the phase you're in. Once you're in the brainstorming, ideation, development phase, that's one thing. But once you start launching and then you start scaling, then I think that's when you have to start thinking about, well, now I need to start hiring or recruiting more people. And it also depends on the objective of the product, or the tool, excuse me. If you're trying to sell to customers, right, then the team you're trying to expand is less a technical one and more a sales force. Right? Or if you're thinking more about research, that also changes sort of the people you're actually going to hire. Are you trying to make this into a business, or are you trying to make this more of a research endeavor? And if so, how will you continue to fund that? I think one thing I've learned, and I'm sure you guys are way more successful and experienced than I am, but just from my own experience in business, and also with the tech products I built, is the team is the most important, less the number and the type of person you are actually recruiting. So the more mature I get, the more I realize that everything comes down to human relationships. Are your values aligned? Do you guys communicate similarly? What are your skills that are complementary? And if you're able to check those boxes and work well with each other, I think that's the most important ingredients for success than the actual size number of people in your team. I hope that was helpful. I don't know if we answered your questions. All right, fantastic. I think we're at time, but we would actually love to meet each and every one of you guys and answer more questions afterwards. So thank you guys all for attending.
Thank you.
Appreciate you all.